in breast MRI, as well as guidelines of practice and how we could have a good quality breast MRI. So what is quality assurance? Quality assurance is the maintenance of a desired level of quality in a service or product, especially by means of attention to every stage of the process of delivery or of production. The guidelines of a standard breast MRI include three main domains: the technical aspect, the images, and the report. These are the two references that I'm going to be using today, one by the European Society of Breast Imaging and the second by the American College of Radiology. So, technical aspects, first of all, the machine. It's been noted that at least the machine should be 1.5 Tesla. There are people that work with 1 Tesla and less than that, but it's been studied and researched that less than 1.5 Tesla is not a good quality image. Of course, this means having a closed MRI machine and having a dedicated bilateral breast coil. And if you are using MRI, then it's important for you to have as well an interventional coil, because if you have an MR only visible lesion, then you're going to have to biopsy it. This is an example of an image using a body coil in a T2 weighted image, and this is how it looks after we have used the breast coil, and we can see that the image value is incomparable. So patient handling, first of all, contrast administration, and I've just heard the discussions about contrast. I agree with Dr. Khaled that there are some lesions that you can see, especially when it's a fatty breast, but the guidelines are that you have to use contrast in MR examination until now. The dose of contrast varies in different studies between 0.05 to 0.2 millimoles per kilogram, but what is mostly used is the 0.1 millimoles per kilogram, and of course it's important to do it within the proper menstrual cycle phase, which is day 5 to 12. This is an example of a case which was fully injected with contrast, but the contrast did not reach the patient due to some problem within the injector. And look here, you'll see the difference. You'll see that there is contrast within the heart, within the vessels, and within the lymph nodes. And this means that you have to check very well for these things before you say that this is a negative study. And this was an axial maximum intensity projection images. This is a classic case of bilateral cancer, and here we can see that contrast has been taken up very nicely. We have our palpable mass over here, as well as the axillary lymph nodes, and both have taken up contrast. We have clumped enhancement, and we have another nodule here enhancing, and the other side as well shows linear clumped areas which were DCIS. So this was a bilateral carcinoma which has showed good enhancement, and we can see the contrast within the heart and the vessels and the lymph nodes. Positioning is very important, and the patient should lie in the prone position, preferably her hands beside her, not to the front, and the breast should lie perfectly within the bilateral breast coil. This is an example of improper positioning, and the arrow points to the areas which are not positioned well within the coil. And this is another example of indentations on the breast which make the image not well visible. And this is another example of improper positioning. Here we can see that part of the breast was not inside the coil, it was trapped and pressed through the coil, and this is how after it was adjusted. So regarding our sequences, it's mandatory to have T1 and T2 pre-contrast, to have dynamic images, and to have either fat suppression versus subtraction. Now, the guidelines say that actually you can do either of fat suppression or subtraction, but they find that fat suppression is very difficult to do, especially to keep it homogeneous in all areas. So most institutions prefer image subtraction, and also fat suppression tends to have more noise. So that's why most institutions prefer image subtraction. This is an example of inhomogeneous fat saturation on the left side over here. And moving on to the ACR accreditation, that's what they say, that exams must include these 4 sequences: T2 weighted pre-contrast images, then there is a pre-contrast T1, an early phase, there must be at least one early phase post-contrast T1 completed within 4 minutes of completion of injection, and there should be at least one delayed post-contrast T1 as well, and they require that the signal-to-noise ratio should be not too grainy. They also require that the sagittal, axial, and/or coronal images be with a slice thickness of less than or equal to 3 millimeters with a 0 gap. This is just a quick recap on what dynamic means, and it means a pre-contrast followed by a series of post-contrast images. In our institution, we use image subtraction followed by a time intensity curve. So the other technical recommendations is that we should have an adequate signal-to-noise ratio. We should have good spatial resolution, which means 1 by 1 millimeters in plane and less than 3 millimeters, less than or equal to 3 millimeters slice thickness, a temporal resolution of 60 to 90 seconds per phase in the dynamic sequence. Also, a uniform fat suppression if you're going to do fat suppression. The voxel size should be less than 2.5 millimeters, and the pixel size shouldn't be greater than 1 by 1, a matrix of 300 by 300, and a field of view of 300 millimeters. This is an example of an incorrectly sized field of view. This is a too large field of view, and this is a too small field of view. So regarding the report, the radiologist must review the pulse sequences and the image contrast, the positioning and the anatomic coverage, the artifacts if they're present. He should revise the spatial and temporal resolution and the exam identification. The report itself must have, if there is an abnormality, it must specify if it is a mass, a purpose, or a non-mass-like enhancement. We must also comment on the morphology and the kinetics, the size of the abnormality, give it a BIRAT score, and give our management recommendations. So, quality assurance is important to ensure production of high quality images by evaluating whether MRI scanner and coils used for breast imaging are performing consistently over time. It should be part of a comprehensive MRI quality control program and may be required to satisfy accreditation program requirements. The breast imaging technical guidelines recommend that the physicist should actually do an evaluation for the MRI system after installation and annually and following repairs. There should be annual quality control of all RF coils. The service engineer should do his periodic and preventative maintenance, and the MR technologist should do daily or weekly phantom scans. He should do these scans for equipment function and safety, center frequency, signal-to-noise ratio, uniformity, and artifact assessment. The potential causes of low signal-to-noise ratio include low field strength, poor coil connection, coil element failure, incorrect center frequency, and incorrect protocol parameters like we have discussed before. There is always trade-offs between speed, signal-to-noise ratio, and resolution. Regarding evaluating the breast MRI coil, we should do a coil inspection to check if all the cables and wires are in place and the coil is perfectly functioning. Check its signal-to-noise ratio, the signal uniformity, and in phased array coils, compare signal-to-noise ratio of different channels and check for artifacts. These are some parameters used during the quality control procedure using a phantom. I'm not going to go through these measurements, they're all regarding the phantom, but it's important to note that the signal-to-noise ratio should be at least 800, and if it is lower, we have to check if the phantom is correct, and if it is, then we have to go back to the company representative. This is how the check should be done with the phantoms in the coil. Regarding personnel qualifications, the guidelines say that the radiologist should be, of course, certified and should have interpreted and reported 150 exams in 36 months and has done 15 hours of Category 1 CME on clinical indications, safety, and function of the MR. For continuing experience and education, the radiologist should see 75 cases and 5 hours of CME over 2 years. Regarding the technicians, they should have supervised MRI and contrast injection, and for continuing experience and education, they should have 50 cases, they should perform 50 cases and 24 hours of CME over 2 years. So to sum up, a good quality MRI examination is actually a correlation between all these issues: the machine itself, the technique we use, the sequences, the personnel, and lastly, the report, in order to have, and also to follow all this up with quality assurance. Thank you very much for your attention.
Thank you very much, Nuran. As usual, very informative in a very simple way.
Thank you.
Thank you very much, Nuran. It's very nice talk, and you remind us of quality control, which we miss and forget in many aspects of our work in public and private. So
I'd also like to thank Dr. Najla Abdelrazek for giving me this talk, because actually it made me study a lot.
Yeah.
Most of my talks are more about cases, so this made me study a lot about quality assurance.
It's a very important issue we always forget.
Thank you.
Thank you.
I know Nuran should be the best one to give lecture about the quality.
Thank you.
Is there any question for Dr. Nuran? Okay, with Dr. Nuran, we close this session, and we have another session in the White Canyon about about multidisciplinary case discussion.
Yes. Thank you for the long day. I'm sorry about the condensed program, and tomorrow we will have a session about breast intervention. We will start at 1:30 after Goma prayer, and we are expecting you all tomorrow, and I hope you had a fruitful day today. Thank you. Thank you, Mr. Chairman. Thank you, Dr. Felix. Thank you, Dr. Wahid. Thank you, Dr. Rasha, for joining us. Thank you.